So I've just started it now, so they should be coming in now. Sorry, you're on mute.
Thank you. I was on mute. Okay, so you may have seen my lips moving, but my colleague has thankfully told me that I was on mute. Let me start again. My name is Sarah. I'm the senior clinical embryologist here at Complete Fertility. I'm just looking at the numbers and the see participants joining. So we're just going to give it 2 minutes or so, just for everyone to settle in. So you have time to grab a cup of tea and just make yourself comfortable as I set up my presentation. Okay, hello. Hi, everybody. My name is Sarah. I'm a senior clinical embryologist. I'm just setting my computer up and I will share my screen with you in a second. Just make yourself comfortable and get yourself a cup of tea. I can see some more people joining. Hello. Right, so today the chat that we're going to have today is aimed at same-sex couples trying to conceive or considering conceiving. Oh, you've lost me there. Here we are. And I will just share my screen with you. Right, okay, just going to set up my screen now. Thank you for your patience. Hopefully more people have joined now and we are just about to start. If I can. Do that. Perfect, okay. I'm happy now. Right, okay, so welcome. I am Sarah. I'm one of the senior clinical embryologists. I've been doing embryology for about 15 years. Before that, I was a pharmacist, so that's a pharmaceutical background. There will be an opportunity to ask lots of questions at the end. Yeah, okay. So I just want to start by acknowledging that this is the first step. So everyone's journey is different. The reasons and motivations to seeking, creating a family, whether or not you've already decided this is something that you want to do, or you're looking at your options. It could be also fertility preservation that you're thinking to do. So today's talk is aimed at same-sex couples. But if you're a single lady and you're on the talk, that's absolutely fine. I would say maybe 98% of this is absolutely the same. So please stay on and feel free to ask questions. There is a specifically tailored talk for single women that we do. So just keep an eye out on that if that's what you prefer. And if you're a heterosexual couple, again, I think around 85% of the information is exactly the same. And if so just stay on if you're already here. So welcome everybody. Sort of thank you for joining me today, and I hope sort of by the end of tonight I would have answered some of your questions to help you sort of understand what is involved in fertility treatment and the options available to you. So you've probably heard things like standard IVF, what is an IUI cycle, to help you navigate the steps of treatment, what COVID means in your treatment, and also, as I said, ask questions. So please, just it's easier for me if you put your questions in the question and answer function so I can track them in the note and not the note. So please, the question, the Q&A function, and I'll get to those in the end. Just for those of you that have just joined, this will take about, say, 45 minutes to an hour, depending on how many questions you are. And obviously, if you want to speak to one of us directly, just give us a call if it's something that you want to discuss sort of over the phone. But I hope by the end of today, we would have covered, or I would have covered, a lot of the sort of those preliminary questions. So just to give you a little background about who we are. So this is Complete Fertility. We're based mainly in Southampton, but we have satellite clinics in Portsmouth, Bournemouth, and Chichester. So you can access clinics that are closer to you. So it's more convenient for, say, appointments such as scans and follow-up appointments. But the main procedure, so we're based in Princess Anne Hospital. And so the main procedures such as terms such as egg collection, embryo transfer, for the IUI, so the insemination, would be based here in Southampton. So just keep that in mind, but you don't have to always come in. And a lot of things now, after COVID, we're very used to doing lots of consultations via Zoom. So you, unless you're physically needed to be here for a specific reason, such as specific tests, you can do a lot of things sort of remotely. So a lot of things that we've learned through this pandemic. So we're part of the Virtus Health, which is an Australian company, and this clinic was acquired in 2018 by one of the biggest providers of fertility in Australia, and they've got clinics in Ireland and also Denmark and Singapore. We are part of this big unit or big organization through lots of different countries. So we are able to stay at the cutting edge and learn from each other and have all the sort of the best technologies that are available that are emerging in other places as well. So it's really good to have that collaboration, embryologists and doctors, with those other clinics in the different countries. Our main aim is to optimize the chance of all our patients achieving a singleton pregnancy, so a healthy singleton pregnancy. So in the world of fertility, we kind of say that multiple, so say twins or more, so more than one embryo, is a risk of fertility treatment, and we want to achieve this pregnancy in a healthy way, and it depends on sort of your situation and your circumstance and your embryo quality, for example. We can talk about that, but our aim is for that healthy singleton pregnancy. We have very high quality evidence-based and it's individualized care. So evidence-based because one of our founders and doctors is Professor Ying Chung, who is head of research in Southampton University. And so research is very sort of active and an important part of our facility. So we don't just offer all treatments just because other clinics offer them. We have to make sure that it's evidence-based, and it will definitely be of service to you. If you want to sort of look at all the add-ons and extra things, you might have heard of the HFEA website, and it does show you which treatments are approved, which ones are still under research, and which ones have no effect. So we're very sort of proud of making sure that everything's evidence-based when we offer it to you. So just to give you an idea of our team, so our co-founders, Julia Paget, which is a very experienced embryologist who is now working with Virtus, setting up clinics all around the world, and Professor Ying Chung, who I've mentioned, is our medical director here, and all the various doctors, depending on whether you're here in Southampton or any of the satellite clinics, you might get to meet these doctors. So there are more same-sex couples having fertility treatment nowadays. So if we just look at the data, say 10 years apart, so 2019, there was 4% of all of the treatment cycles were involving female partners. That's 10 times more than that was being undertaken in 2009. So it's a lot more mainstream. A lot more people are seeking treatment, fertility treatment, and for insemination, for example, a big proportion of patients are same-sex, using donor insemination. So it's a very routine procedures that we do every day. So you may be considering perhaps starting a family together. As I said, there might be single women on this talk as well. So you might be thinking you want to have a family by yourself, on your own. And so you will, in both scenarios, we need donor sperm. And there's also something called shared parenthood. Okay. Another thing is to do some sort of MOT. So just to know your fertility, your kind of your fertile health, and find out what's going on. So sometimes a lot of things come out from these investigations as well. So sometimes just knowing your general health is important. Right. So I had just said we have shared IVF. So when you enter into, say, a treatment partnership, so you're together coming through for treatment, you sign all the legal parenting consents. So by law, you are both the legal parents. So it doesn't matter where the eggs come from. Once you've named each other and signed the correct forms, then you are both the legal parents in the eyes of the law. So just to make sure. So the donor is not the legal parent. The donor of the sperm has no legal grounds at all. They donate, and that's it. And then here it says your partner is recognized as the legal parent. So why seek a fertility clinic? So definitely a recommendation would be to go through a reputable clinic. Because you know that the donor sperm has been screened very well, it's of a good quality, and there is something called the 10 family cap. So every donor is only allowed by law to donate to 10 families. So a family doesn't mean one child, and then those 10 people or couples, and then each family can have more than one child. But it just means that it's limiting the number that a donor can be used. For example, some countries don't have this limit, and there's some funny movies, and American movies that you might have seen about sort of donors. But in the UK, it's very much regulated. And there is a registry. So all donors to us and you are anonymous, but they are in the face of the law, they have their information, and the child's the born child has the right to then contact the HFEA, the governing body, after their some information after 16s, and more information, identifying information after they're 18, if they wanted to find out where sort of their origin or their relation came from. But I mean, couples may or may not choose to tell their child, but that is just the law in England, and it comes from the right of a person to know where their genetics have come from. And these donors have to have specific know some hereditary diseases, and it's very regulated. So you'd have to go, our recommendation would go with a sperm bank that is certified within the UK, and not say something that isn't certified with the UK. Okay. So some more information. So we'll go into all the sort of different types of treatments that we offer, and what you might be thinking about or considering. And also counseling is available and is required when you're going to use any donor gametes. Gametes is just a fancy science word for sperm and eggs. So this is our donor team. So we've got a dedicated donor team that will be dealing with you guys. Actually, there's 2 Amy's in it, Julie. I haven't updated the slide. So that's your point of contact. You have a dedicated team that will be your point of contact, and they have all the information. They'll also provide you the information. We have our own donor bank. So there are the other external donor banks that we're happy to use, and they'll give you that information. But we also have our in-house donor bank. It means that there's no sort of waiting time or delivery and all of that. And they can also advise you on sort of which programs you would be suitable for. And I'll explain what egg sharing is in a moment. So you might be thinking, so what type of person donates their sperm? Again, if we look at the movies, we sort of, college students and, just wanting to make some money. But that's not the case in the UK. Again, it's very, very regulated. They are only compensated for their travel, say, for example, expenses. It's not a money-making business at all. In fact, they have to dedicate something like 9 or 8 to 10 visits to the clinic, blood tests, lots of sort of counseling, a lot of things. So there's a lot of investment from these men that are wanting to donate. And now that they know that they can be identified, the type of person that donates, for example, say things like, well, they knew they're a member of the family struggled to conceive, they want to give back, they want to help, their best friend went through it, things like that. So the really nice stories. And what you get also to see is a pen portrait from the donor when you choose which donor that you want. We currently have around 20 donors to choose from in-house, varying sort of professions, varying ethnicities, and sort of hair color, eye color, depending on what your preference is. You can go through their profiles and choose, as I said, the 10 family rules. So that's very regulated. And at 18, the child has the right to contact the donor if they want to do that. So once you've decided or discussed with our donation team that you want to look at our donor bank, obviously no obligation, you can look at the other reputable banks, they'll give you that information. This is the kind of a special login, and you can go in and look at all the information and choose the donor that's appropriate for you, and then they can help you reserve it, and you can discuss how many sort of vials you need. Vial is like the container that one sort of sample is in. You typically need one sample per treatment. So this is the kind of information you would get. There is no photo, that's just the slide. So it's just this information here would be the information that you would have about any particular donor. So your sort of ethnic group, eye color, hair color, height, weight, blood type, occupation, and then the type of treatment that this particular donor would be suitable for. That IUI just means intrauterine insemination. IVF is in vitro fertilization, which is the standard IVF. This is the insemination. And then ICSI is when you need to use a more invasive procedure, which is that needle going into an egg. You might have seen that sort of online or on television, and I'll show you some videos. So yeah, so there's no pictures with the donors. They're not identifiable to us or you or staff or anyone except their as we discussed. Right, so there's something called mutual or reciprocal IVF. So as we have stated that both partners are the legal parent. So if eggs from one partner, we use donor sperm, the other partner is named as the parent and is the legal parent, not the donor. There is a way to share the process. So say, for example, the eggs could be harvested from one partner, and then the embryo could be implanted in the other partner. So you're both involved in the process of coming through a treatment. And this is just one of the sort of paths that you may want to consider. And with donor sperm, it could be a known donor. So if you have a friend or someone that wants to be involved or can be the sperm provider for your treatment, they would still go through the very rigorous screening and counseling that any donor would go through, so that you know and they know sort of all the medical history that and things. Anything that does come up obviously might not be disclosed to you originally, but you'd have to know before you go ahead. So that's just something to keep in mind, that sometimes a lot of things are uncovered when you have all these investigations just for your friend or that's coming through with you. So just something to consider if that's something that you want to do. Right, so I had mentioned egg sharing. So what egg sharing is, there we mention this at every talk. So anyone that's there's lots of sort of qualifying criteria for this. And it basically says that you can, if someone under 35 within sort of no subfertility, all sort of good prognosis patients, so are donor team can advise you whether you fall within these criteria, and the doctor can have a consultation with you. So it basically says that you can, by donating half your eggs, you basically get free IVF, okay? And so you might think, why would I give away half my chances? Well, you don't actually give away half your chances. The results and the outcome and the pregnancy rates from the egg sharing group are exactly the same, if not slightly better than the general fertility population. And it's because there is no underlying subfertility in this group of patients. We often have collect lots of eggs. There's a minimum number of eggs that collected then you can that you can share. So you have to have at least 8 eggs, for example, to give each side a good chance. It is a sort of a really lovely sort of altruistic thing to do. So you just do something sort of good. If that's something that you feel is for you, we're happy to discuss that further. Just either write this number down, or you'll find the number on our website. There's definitely, you see the counselor and you discuss what this means, what the implications mean of going through something like this. So just move on. Right, so that was just a bit of background information specifically to sort of donor sperm and things. Moving on from here, I'm just looking at my notes. It's pretty similar to all the talks that we do. So again, if you've managed to sit so far, if that top part was not relevant to you, I hope you're here and we'll listen to the rest. Great. So how to start. So generally, in terms of how you can self-refer, so you could be a private patient, or you can get that initial referral from your GP. So you just tell them you are thinking to conceive and you want to see a fertility specialist. Okay, and then after that, you'll have a consultation with the consultant. They will take a detailed medical history. They review your tests if you've already done some with the your GP. Sometimes they ask for more tests, more specific ones. They check things like, are you ovulating? Are your tubes open? Do they allow eggs to pass through? Okay, all of these different things. They give you the information about the treatment options available for you. They make a plan for you together with you and your partner, if that's relevant. And then sometimes these investigations show that there needs sort of further medical attention. So that's kind of going down to after investigations, you may need something. So maybe surgery or something minor or something might come up that needs sort of treatment. And then they will be able to refer you back to have your fertility treatment. The good thing about being in a hospital is that the doctors can follow you up. So they do have their clinics. They are within an NHS hospital. If something does come up that can be done under the NHS, for example, if you don't qualify for NHS funding for fertility treatment, but if something does come up from those investigations and can be done under the NHS, they're very good at sorting that out because they're within that sort of private, but also within the NHS a hospital, which is really a good advantage. So then once you've had this investigation, they can refer you back. So there's continuity of care here. Right, so if you want to, these are our lovely nurses. So the top really smiley bunch. So what you do with the nurses is that you, well, just go through consultations. You go through the procedures and information that has been laid out with the doctor. They discuss your test results. They give you detailed instructions about your medication and plan, and sort of teach you about the medication, sort of how to use certain, say, injections, if that's been prescribed to you for both and your partner if appropriate. They're very experienced staff. They're really lovely, friendly bunch. And basically, we typically want you to stay with 1 or 2 nurses. Obviously, everybody might go on annual leave, or they might not. The same nurse might not always be there. But you'll form a good relationship with your nurse throughout your journey. They are your point of sort of contact with us. But again, you will have your donation team that's sort of coordinating it all for you as well. So It's really nice. And when I said that you would have your specific set of 1 or 2 nurses, but if you feel like your personalities aren't getting along, just say, because it's a very personal thing. So just speak up, let us know, and we can sort of find you someone else that is more sort of suited to your personality, if that's kind of if you're just not getting along with that person. So don't worry if the doctor or the nurse, they're all lovely, everyone's a little bit different, so I'm sure we'll find the right fit for you once you're here. So just to give you an outline of what to expect in terms of treatment. So if we're doing donor insemination, okay, so by this stage you would have already had the doctor and nurse consultation, and any surgery needed has already been done, and now we're starting treatment. You call and you start a medication that the nurses have taught you how to do. Excuse me. So you call us on day 1 of your period, okay, and then we have a baseline scan with a nurse or an ultrasonographer. This is to check that everything is normal and healthy before we start. If not, they may discuss with you waiting the next month. Okay, so I'll just kind of point here. So your period day, you do some hormones and some tests, they do some scans, and this is to sort of prepare your lining, to make sure that all your cycles all in sync and ready. What we would do is, if you're having donor insemination, then that would happen sort of at the correct time when you've got 1 or 2 maximum follicles. That means they contain the eggs. They give you a trigger injection that will release the egg at the correct time, and then the insemination happens on a specific date. The sperm that's inseminated has been processed in the lab, purified to the best swimmers, and I'll show you some pictures once we get to the lab section. And the sperm is placed closer to where it needs to be. Right. So here, that's the sort of it's transvaginal, okay, and then this is your uterus, and then the sperm is put really close to the uterus. I mean, this is the fallopian tube, and those are the ovaries. So the egg is released, it goes kind of flows through the tubes, and then sperm is really close, and hopefully we hope that fertilization will occur. Okay, so the difference between, say, standard IVF down here and ICSI and IUI is that the or DI, which means donor insemination, and that means intrauterine insemination, is that it's less sort of harsh in terms of the drugs. When we only want one egg ideally, but maximum, if you have 2 follicles, you can still go ahead, but that will be monitored. With the IVF and ICSI, there's a lot more eggs are harvested and then collected. So there's a lot more sort of medication involved in this path. And then eggs are removed using egg collection. So I think I've got a slide to show you. That's a procedure that's done under sedation using, we have consultants that will do the anesthesia for you. And then the eggs and embryos are grown in the lab, and then the embryo is transferred to you. So the embryo transfer isn't under sedation, it's just like a smear test, very quick procedure. And the lab between these 2 dates will be giving you a lot of updates to let you know sort of what's happening in the lab. If we're doing the IVF versus ICSI, which is just basically a more, this is injection of sperm into egg, and I'll show you, or sperm into egg, correct, and this is IVF when the eggs and sperm are left together. As I said, on average we expect to collect about 10 to 12 eggs, but we may have 1, it only takes 1, we may have 20. They wait until the follicles are a certain size, then you're triggered injection 36 hours before the procedure. So typically they will say, take this medication at 11 p.m. at night, and it's a very important to follow all the information, because we're dealing with nature and biology, and we're trying to mimic that cycle to get everything at the right time. Right, so if I move on, so a home pregnancy test is very accurate, so you just do that, and that's typically about 2 weeks after you've had the procedure, and then you book in your, or the nurses will follow up through this period of time, and then hopefully your pregnancy scan. Right, this is the lab team. So this is my team. I'm not in that particular picture, but they are really lovely, very diverse group of lovely ladies, lots of experience, lots of years of experience, and very meticulous group of people. So you'll be speaking to us over the phone throughout the week between the egg collection and embryo transfer. Okay, so let me give you an idea of what the lab looks like and what we do in the lab as embryologists. So an embryologist looks after your egg and sperm, the embryos, basically whilst they're outside the body. All the equipment in the lab is aimed to mimic the natural environment inside your uterus or the reproductive tract. That is my colleague Claire demonstrating very nicely there. This is a microscope. She's doing a procedure, and there's an incubator there. I've got more pictures to come. Great. So we have embryoscope technology, which is time lapse. It's kind of the most advanced technology available at the moment. And basically it means that we don't have to take embryos out of the incubator to check them every time once they've been created. They are tucked away in an incubator, and we have a continuous video. So it takes 10-minute photos, and then we have a nice time-lapse video. So it's really a helpful tool for us to see anything, not to miss anything in terms of development. Traditionally, embryos are left in the incubator and checked at specific timings, which are the ideal to see certain things. But this way, nothing is missed, and we have a full picture of how the embryo is developing. And I've got a video to explain what you're looking at there. That's an egg that's developing into an embryo nicely in the lab. It also helps us choose the best embryo. So obviously we're guided by human embryologists, but there's also AI technology that helps grade or assess how embryos are developing based on timings of when things are developing. Right, so if we look at the egg collection, so there's a vaginal probe, a thin needle. So this is the procedure that's done under sedation. So you won't feel any of this happening. Consultant anesthetist there, a doctor doing the procedure. The follicles here, that's your ovaries, they go into the follicles, and they sort of suck up the fluid that goes through the tube into a test tube. So that's kind of where the term test tube baby has come from. But we take these tubes as passed to the lab, and I'll move on because that's a bit maybe graphic. Right, so what we're trying to find in the lab are these eggs. So we look at them under that microscope. If I go back, that my colleague, oh, not here, was looking under. Here, okay. And we pick them out one by one as they come through. And next slide, yeah. So eggs look like this when they come out. There's an egg inside and a fluffy cloud of cells around. These are called cumulus cells. So the egg needs those cells to support it. So if we're doing standard IVF, okay, or that's how the egg will look like it's floating through your sort of fallopian tube. Those cells help the sperm sort of pass through to inseminate, for natural fertilization to happen. These are sperm cells. They're not shiny. That's just the microscope. And then this is when we mix egg and sperm together, if you can see the proportion of size, so eggs are very big. It's the biggest cell of the body, just interesting to know. So you can kind of see them by naked eye as a little speck. So it's quite a big cell compared to other cells. This is the ICSI, what I was explaining, that we would inject a single sperm. So you see how tiny a sperm is, cell, and that's the egg, and then we inject it. So if you can see, it's a quite invasive process. You might think, oh, why don't we just do ICSI for everybody? There is a damage rate. So if we don't need to do ICSI, it's less than 5%, and it's a very routine procedure. About 50% of patients are standard IVF and 50% are ICSI. If the semen sample, of sperm rather, is of poor quality, or it hasn't survived very well the freezing and thawing, we might recommend doing ICSI. If standard IVF hasn't worked in the past, for example, again, we might recommend using the ICSI, intracytoplasmic sperm injection. Okay, so it's kind of quite invasive, as you can see. So it wouldn't be the first point of treatment, but if it's needed, then it's absolutely fine. Once the egg has fertilized, the results are absolutely the same. So it doesn't, just because the sperm is inside an egg doesn't mean it's definitely going to fertilize. Eggs are going to fertilize about 60-70% of the time. That's the expected rate. So some eggs were just never, or eggs and sperm combination were just never destined to work. So this is a video. So if you can see, that's the cloud with the egg inside. That's the little sperm swimming around, and that's standard IVF. Okay, so the eggs and sperm are mixed together. First, the sperm will sort of swim its way through the that cloud of cells, inseminate the egg, hopefully fertilize. So what happens is when one sperm gets through, the shell toughens and nothing else gets through. Okay, this is ICSI. So I can show you a video of the, this is the, if you can see there's the sperm in there, this is the holder, that's just under a big microscope, which I will show you in some pictures coming up. So what we do is that's the needle. This is very small. This is happening under a microscope. It's very microscopic. You almost can't see this very thin glass needle. They're actually, and you can see you penetrate the eggshell. You have to go in. You have to suck up some of the cytoplasm or the fluid inside into the needle to make sure that this membrane breaks. So it takes a moment, and then you see it like a gushing out. Okay, there we go. And then there's the sperm still there. And then you can go, and it goes back in here. So you know, there's the sperm. So you know that, oh no, there it is. Yeah, here we go, here it is. So you know that the sperm is definitely inside, not trapped outside in this membrane. And then the egg recovers and miraculously fertilizes, and that continues. So next slide. Right, so once fertilization has happened, whether it's standard IVF or the ICSI procedure, the next day, so the egg collection and insemination we call day 0, okay? And then day 1 is the day of fertilization check. So that's the next morning, we would call you with your fertilization results. This is what a fertilized egg looks like. So we have the polar body. So if I go back to this, so one egg is got half the genetic information, and the sperm has the other half. So what the egg cell does is it pushes half of the chromosomes up here, so kind of it pushes it out, and then the sperm has the other half to create a full person, right? So fertilization is these two signs of what we want to see. So you have those bubbles out here, there's 2 circles here, and then 2 pronuclei. One comes from the male, one from the female. So we can't tell which is which, but that's the image that we want to see. Sometimes there's too many of these or too little. So there's 1 or there's 3. We know that that's not genetically normal. There's too much or too little genetic information, and we can't by law use those ones. So it's not uncommon to have an embryo that has fertilized abnormally. We would let you know. Not all our eggs are destined to work. The very few good ones that are you and I are the ones that will hopefully continue to develop. So the next stage of embryo develop, we would call the cleavage stage. So this is day 3. This picture is a day 3 of embryo development. On day 2 of embryo development, we want to see the first division between 2 and 4 cells. And then day 3 of embryo development, we want to see sort of 6 to 12 cells. This is an 8 cell. So all these embryos are textbook looking. So your embryos might not look exactly like a textbook embryo, but this is just so that you are aware. And when you see a photo of your embryo, hopefully it does, look like one of these. And I'm just kind of clicking the wrong direction. Bear with me. Just there we go. Right, so after the cleavage stage, so we count the number of cells, we give you a call on this day as well. So every kind of 2 days, we contact you from the lab to give you an update. And then we typically would recommend waiting till the blastocyst stage. So you may have heard that term. It's basically just a fancy scientific word for what an embryo is called on day 5 of embryo development. So this is what a blastocyst looks like. It's the first time in our life where we have differentiated into 2 different cell types. So up till this stage, all the cells are the same, and they're every cell is destined to be any cell in the body or in the fetus or placenta. So now here, the center or the core is what is going to be the fetus or the baby, and the outside surrounding cells are going to become the placenta. So this is the first time in our life that we have differentiated. This is, it looks like, say, I would imagine it like a football. There are cells on the outside, or the shapes of the football, they're all connected to a core. Okay, and we can, good quality embryos, we can see that very clearly here. So our aim is to see a blastocyst to transfer. Most embryos are going to stop, drop out of the race rather, between day 3 and day 5. That's not to do with culturing them in the lab. So whether an embryo, if we transferred an embryo early, if it was never destined to work, then it won't make a blastocyst. Okay, so it's so the recommendation is to wait and see if it gets to the next stage, so that we're not transferring embryos that were never going to work. We find out that information sooner rather than later. So when you have a blastocyst, you know you're doing 2 weeks of medication with good potential embryo. There's always a chance that embryos don't develop, and there might not be anything to transfer. So if embryos stop, we know that genetically they were just not correct, and then sort of in terms of like nature, they've stopped. But it's about 1 in 3 embryos. Okay, so if you have a good number fertilized, we typically expect about 1 in 3 embryos to keep developing. Okay, right. So then what happens is between day 5 and 8 in nature, once they're inside of you, the embryo will break out of the shell. That's kind of hopefully implanting. It's like a big bubble with a core there that is hopefully going to become the baby. Right, so I'll talk you through this video. So this is the little bubble I said was the egg that we know it's a mature egg, so only mature eggs can fertilize. Those are the pronuclei. So I said that was the male and female pronuclei in the middle. Then they disappear. Then you can see 2 cells. Then it will divide into 4 cells. So we're in day 2 now. And then we're moving on to day 3 of embryo development. So any 6, you can count 1, 2, 3, and it's almost 8 now. 8 cells. Then what happens by day 4 is all the cells sort of start fusing together, and you can no longer kind of count them. It's like sort of cells all pressed against each other, and then a cavity starts to form. Okay, that's cavity fluid, and then the cells differentiate into that core, that's the fetus of the baby, and then the outside. And if you saw there, that one kind of popped out. So it started, if you just keep an eye there, press play, pop. So it's starting to break through the shell. And as, I don't know if you noticed, we'll kind of go back, the shell is pretty thick. And then as the embryo gets bigger, it thins out the shell until it can break out. Okay. I'm being a typical embryologist, being fascinated by the video and making you watch it again. So I'm going to keep going. Right, so something very important to mention is everything within a fertility treatment clinic and within sort of medicine is typically double witness. For example, nurses dispensing drugs, they need to be getting a second person to check. So we have double witnessing, which is a legal requirement, but we also have something called RI witnessing. So not only are we 2 humans, but we're also using barcoding on all the dishes and tubes for you. So we work within a designated area under the microscope with the readers. And so there's a traceability and tracking of any containers that come on here. So say, patient X, everything's fine. If it's patient X, patient Y, then a very loud alarm sounds, and it's kind of another alert system. So it's 2 people checking critical points and also always working within that environment, everything connected with barcodes and name checks, etc. So I mentioned early on about counseling. So counseling, you are entitled to have up to 6 sessions, but if you ever need more, the counselor just prescribes you more. So it's all included within whichever package or treatment that you come through. You're entitled to it, and it is a legal requirement for using any donated gametes. But as I said, you can access it any time. Our counselor D is amazing. She is available for both patients and staff. And I would highly recommend that you do take advantage of seeing her. It could be just a phone call or via Zoom or in person. And there's so many things that she can help with just coming through fertility treatment. So their counselors are specific fertility counselors. So it's a very different type of counseling. So there's quite a few different sort of support available to you. So we also have an app. So this app basically tracks, if you're happy to sign up for the app, you don't have to. This is in-house or in clinic, part of Southampton University. And it's basically The nurses program it with all your medications, send you alerts. It also has a mood management and information, coping sort of strategies. Eventually, what they're trying for this app is to learn and be able to analyze your stress or your distress levels and be able to trigger a phone call from a nurse or a medical professional. So it's not quite there yet in terms of being able to act on your behalf, but it's collecting as part of a research project that collects sort of data, and hopefully will be up and ready on that particular aspect. So it's very exciting. But again, you can, it's easy, it's a nice thing. We're all on our apps now to kind of keep track of your medication, and just let the nurses know if you want to use it. So other support available for you is there are support groups on Facebook, for example. There are lots of support groups that you can be part of. The information is on our website. So they are moderated by the counsellor. It's also kind of finding people that are going through the same thing. If this is something for you, please just mention it at consultation or with your nurse, and we can get you set up with it or with our donation team, depending on who your first point of contact is. So another thing that is available in terms of support is a buddy program. So you might not want counselling sort of beyond what's required, and you might not sort of want to be on a sort of a social media platform. Obviously, they're private groups, but it might not be for you. But you might just want to be one person that's going through the same thing. So if you just tell our donor team or your nurse, and then they can just kind of put you in contact with someone that's also asked for this kind of support, and then you guys can just kind of take it from there. WhatsApp, go for a coffee. You know, that's just something that's out there for you or your partner or together. Other things you might need help with, you know, nutritionist or GP, sort of BMI, hormones, lifestyle, nutrition. So all these things are complementary to make it a full service. So once you've met your doctor or your nurse, and say anything's come up on that front and you need help or advice with, you can book a consultation here as well. So the recommendation is always to look at reputable sites when you look at information. So any reputable clinic's website will have links to the right places. The HFEA is the regulating body, okay? It's definitely, if you are looking for information or how to choose a clinic or what a definition of something means, I would definitely recommend you, if you have not already, go onto the HFEA website. You also have all the data from all the clinics, so the success rates, all clinics get sort of monitored by inspectors, so inspections, and you'll have their reports. All of these things are available for everybody online. Just kind of, I'm not going to go through success rates. They're on our website and they are on the HFEA website as well. So there's just something to keep in mind when you are looking at data. Also make sure you're comparing like with like, so age groups do affect the results of what you're looking at. So a very common question, I can see some people have written questions, so I'll get to that in the end. I'm almost through the slides. I appreciate there's a lot of information, so don't worry, it is available online. Do we get treatment under the NHS? As same-sex couples, you must demonstrate a failure to conceive after 10 inseminations to be eligible for IVF. Okay, but most patients can get the first appointment on the NHS, so the consultation. You might, well, after you've had to pay for, I mean, hopefully this, you know, might change in the future, but you would have to pay for 10 inseminations before you can get standard IVF. So it might be just worth looking into sort of how much an IVF cycle might cost and all of that, but that's something to look into. And obviously you can talk about it in an individual basis, but there isn't very much funding for same-sex couples unless you are able to prove that you are subfertile. So there are 0 interest rate payments available for private treatment, and if you are interested in that, it's spread over 12 months, and definitely talk to our finance team. Also something to mention, so this is kind of like an insurance company that lots of fertility clinics deal with. And basically, they offer a range of financial packages that help to reduce the uncertainty of how much treatment might cost you. You pay a fixed fee for a program of treatment, and in some cases get a refund if you don't have a baby. Depending on which package you choose, there are sort of criteria for eligibility, so just have a look, and there is a medical review. If this is something that you're interested in, just go onto their website. So it's a company that kind of particularly do these kind of packages. So you pay them, and then they deal with lots and lots of clinics. So it's not just for us, and it's quite a reputable way. So have a look at it if this is something for you that you want to consider. But there are sort of criteria, and age does come into play with what packages are available to you. So just kind of, I know sort of COVID is such an old topic now. We're all kind of used to living with COVID. So staff do sort of test regularly. Obviously, if anyone has symptoms, they don't come in. The majority of our staff are vaccinated and offered to everybody. Just to kind of, we do try to reduce sort of footfall, sort of unless you have an appointment, sort of patients can't just come in. But the two kind of questions that might come up is, do I have to delay my fertility treatment if I want to be vaccinated? So there's that tiny bit of delay is absolutely fine depending on your age. So if you're under 37, a couple of months won't make any difference. If you're sort of more towards 40, it might be. So we would definitely, we'll probably say don't delay, and you can have treatment as soon as you've had the vaccine. Just depends on sort of where you are on that, and kind of ask us directly so that we can help you. There's the vaccination advice is British Fertility Society there. So just kind of go directly to the source when you're looking for information. Again, on the HFEA, the Human Fertilization and Embryology Authority. So they regulate all clinics in the UK. Okay, everyone has to have a license. Everyone is reviewed every 2 years with interim inspections. Everything is on that website. It is a very good point of information. It gives you information and what sort of they say about each clinic on there, and the ratings, etc. So I'm almost at the end of the talk. So basically, this is just a summary slide of everything that we've covered today. What I'll do next is, typically when we used to have these talks or these open evenings in the clinic, so it was a really good opportunity to then take you and walk you around to show you all the different rooms and the lab and all of that. So I'm really hoping that that would come back soon, because I wish I could see you guys. I know you can see me. I'm just going to click through now all the different rooms. So that's a waiting area. That's just my colleagues walking around. So the clinic was refurbished when it was taken over in 2018 by Virtus. So that's really nice and new. And you have, you've seen the lab pictures. That's the embryoscope. This is the cryo storage room. So this is where this frozen sperm is kept, and our photogenic colleague Claire again. This is the ICSI microscope. So this is where I was explaining about the holder and the needle. It's all done under this big microscope, and we do it all using sort of levers, and it's very kind of sci-fi and very cool. Well, I think it is, at least, but I would say that I'm the embryologist. Right, so these are some private rooms. So there is an option to have a private room, or there is a big day room that's really beautiful with a nice sort of bright windows. Another treatment room here, just to give you an idea of what to expect. This is the recovery room. So it's 4 cubicles, nice and spaced out, really nice. Typically, you won't be here very long. So if you're coming in, it's sedation. Maybe we would tell you come in for sort of 7:30 or 8, depending on when your procedure is scheduled for. And by midday, typically you're leaving. It isn't a long day here. This is the procedure room where you have your egg collected. There are monitors, so you can see what's happening once you have an embryo transfer. Obviously, for egg collection, you will be you come in sort of walking, sit, have sedation, and then be taken back to your bed. So thank you for listening today. Typically with these open evenings, what we have is just a little thank you and a little offer for you. So if you do book sort of an appointment and you want to have donor sperm, just let the administration know when you call up that you were on the talk. They'll have a list of names anyway, so they'll know that you were at the talk, and that will give you that sort of little discount there. So thank you very much for listening. So what I'm going to do is I'm going to try to see my questions now. I think we've got some time. If I can come out of, stop sharing. Right, I've got some questions, great. So just bear with me, I'm just gonna take a moment to read a question and then answer. Is there a difference if you are referred from a GP rather than a private self-referral? No, absolutely no difference. So the only difference might be how soon your GP can get the referral or the appointments, but once you're through the door and you have that first appointment, it's exactly the same. Okay, so there's no differential treatment. There is a dedicated administration for private patients, and there's an administration team for NHS patients, just because what they have to deal with is very different. So it's a very different sort of path and knowledge. So that's the only sort of difference in the administrative team. But for you, you will not notice any difference. You'll just know that if you are growing through funding, that team will have that knowledge. Okay. Okay, so how long before egg collection do you need to remove the coil? So that is a very medical question, so I will not know. But what we would do is you'd go to your initial consultation and they would put in the plan. Typically what you want to do is get everything back to sort of natural cycle. Okay, so what any contraceptive is doing is that it is kind of giving out certain hormones so that no egg or embryo implants. Okay, so it's just about coming back to that sort of flushing that out and coming back to the sort of natural cycle and being able to test your hormones. So it's definitely something to discuss with your doctor. On the embryoscope, does that give you, your team, any early indication to success rates? So it's not really the embryoscope. So the embryoscope is just a camera. So I wouldn't say the embryoscope adds any thing. So if a clinic isn't using that type of incubator, their rates could be equally as good. What it's doing is it's giving us lots of information about how the embryo is developing to help us make the best selection. We know that good quality embryos that look like a textbook correlate with better success rates, but it's nothing that the embryoscope does specifically. Something maybe can be said about that if you look at the research, that because it's less handling, they're not coming out as much. So just leaving the embryos to kind of relax in their kind of comfortable surrounding might be beneficial in terms of embryoscope. Also, if you have lots of embryos, what it does is it gives us it ranks the embryos to which ones they think they have better potential, but at the end of the day, it's down to genetics. So we can't see genetics, but we know that certain things correlate with higher success. Okay, I hope that answers your question. Yes, okay. Next question is there a BMI requirement criteria? So yes, there is. I think the maximum, there is a maximum, and I think it's off the top of my head would be 35. But different, say funding, sort of 30, under 30 rather. I'm just looking at the NHS criteria for funding, and sorry, 35 was the age. So under, it has to be under 30, but that's a discussion to have with your doctor. And there are ways to help manage sort of weight and get you healthy. Just generally, the healthier we are, the more fertile we are. It's just the body being prepared for the sort of journey that it needs to go on and all the requirements. So just ask. It would be typically, I don't think it's a solid cutoff if it's, say, for example, insemination, but if you're having sedation, so anesthetist might not be comfortable performing a sedative procedure on someone that's got a very high BMI and also too low. So there's also a lower limit as well. Right, next question. Just bear with me. Yes, someone's just put a question on the notes. Yes, we can self-refer to the service. You don't need a GP, that's fine. You just call and book an appointment. Okay, so I'm just screening the questions just to make sure that it's beneficial for everyone to read them out loud, okay? So due to work commitments, we are unable to start treatment for another 6 months. It is still worth getting fertility tests done now or wait until we are ready to start treatment. We are 30 and 37 years old. Thank you. Lots of these questions I think are beneficial for everyone. So the gold standard of fertility is under 35. But having said that, under the 36, 37 is also quite fertile, and 38, 39 is another group, until 40. Over 40 is another category. So as long as you're under 40, there's a really good chance of success. Over 40 to 42 is slightly decreased, but not impossible. There is success, but it's if you had said you're 39, I would say 6 months would have made a difference. Because of your age group, 6 months will probably not make a difference, depending on whose eggs you want to use. But in both cases, very good success rates. We are in a very good prognosis group because there is generally, obviously, there might be underlying subfertility there, but generally we just want egg and sperm to meet, and then everything else hopefully will be okay. Just to keep in mind, natural conception is 30% chance. Okay, so IVF or fertility treatment or insemination gives you that chance as natural fertility. So it's not 100%, it's kind of 30%. So sometimes you have to have more than one cycle to achieve success. Right, so I'll move on from that. You can have the tests. So as long as they're within the year. So say, for example, blood tests and scans will be needed to be repeated over a year. But if you wanted to get all the tests done and you know it's 6 months, so at least you know in 6 months you can start instead of sort of losing more months after that. So it's something to consider. Maybe if you can do tests, just get those done and then be sort of ready so that you're ready to start within 6 months. So that's a good idea as well. But yeah, time's still on your side, don't worry. Okay. How do you determine which partner is better for reciprocal IVF? So it's a very good question. So you both get assessed, okay? Age is probably one factor that's pretty clear. So if a partner is 35 and one is 40, then it might be sort of the younger partner just to harvest the eggs. But it could go either way. You would have scans and some tests, and then we can assess the fertility of you both and decide. And sometimes it's a preference. So someone might be more comfortable carrying a pregnancy than the other partner. So it's very sort of specific to you and how you feel and how you want to go through this process. But if it is sort of on a fertility front, they can assess fertility and let you know which partner would give you the higher chance. If it's the same, then it's just sort of down to you guys to decide. Right, next question. Okay, can you provide further information on how egg sharing doesn't involve giving away half of your chance? If half of the eggs are donated, are you not losing those eggs at that and the possibility that you could use yourself? So for you to qualify to be an egg sharer, so basically the answer is no, it doesn't, because we look at the data of everyone in that group. And you look at the percentage of success, and it's equal to those that don't share eggs. Okay, it is because you're stimulated or you are quite fertile and you're producing lots of eggs. Okay, and you'll have a minimum number of eggs that you keep for yourself. And I said that was you have to have at least 8, so 4 for you or 4 mature. If you have less than that, then you can't share the they don't ask you for money. That's just kind of what happened. And then you just kind of go ahead and keep all your eggs. If it's more than a certain number, because you've entered in that agreement, then you donate the half. So both groups, so the recipient and the sharer, do equally as well. And it's because it's a numbers game. So it's numbers percentages. So if you have, as I said, it was 1 in 3 embryos that continue to develop. So if you have at least 4, then your chances are really good. If you had 10 eggs for you and you didn't share, you might have more embryos, say, to freeze for the future, but you might be producing 20 eggs or in that category. So you have to qualify where the outcome is going to be favorable. So if you are already sort of your fertility is affected, then you wouldn't be eligible for this treatment. But in terms of just outcomes, it doesn't affect your overall chances of success, because your particular group of patients are quite fertile and do really well. Generally, how long are you taking hormones to prepare for the egg collection? About 2 weeks. Okay, so it is tailored. So depending on which protocol, there are different protocols. It could be 1 week, could be 2. So it's not months, if that helps. Sometimes you might be advised to go on some sort of contraceptive pill before to regulate cycles if that's needed for you. Or sometimes it's a slightly different route, but I would say on average maybe 2 weeks. So I think I've got to the end of those questions. I've got something in the chat. Let me just check. Oh, I've answered that already. Well, thank you very much. I'm just going to give you a moment for anybody to write a question. But really nice questions. Thank you so much. And I really hope that I see you in the clinic and in future that I get to do these talks in person, because I can kind of engage and know sort of or see what you're thinking. But I hope I've answered some questions. All the information is available for you online on our website. Also, you can call the lab or the clinic directly. The administration team are really good at answering questions about how to book and when and how. You can call us if you want to talk about anything in particular, or more specifically, if you are same-sex couple using donor gametes or thinking of egg sharing or reciprocal IVF, then I would recommend that you call the donation team, because they will be the best people to answer your questions. Oh, thank you. Thank you for that message. Okay, good night, everyone. And hopefully you're all feeling well informed after this talk.